And now I tell women in my audiences, you know your body. You know when something is just not right. My stereotype of what a heart attack looks like didn't match how I was feeling.
In your case, you were lucky. You were just lucky. You were lucky you did not die from heart disease.
Only 52% of the women surveyed knew that chest pain is a symptom of a heart attack. I couldn't even believe that. How is that possible? And what do we need to be doing better to get that message across? Because clearly what we're doing is not working.
I feel heart disease in general, and we will, especially in women, is totally neglected in terms of screening. Hi everyone, it's Dr. Dave, your favorite preventative cardiologist, and welcome to On Call with Dr. Dave, where I speak to some of the most influential people in the world on nutrition, fitness, and medicine. Here on Call with Dr. Dave, my goal is to bring awareness to healthy habits that will hopefully translate into heart disease prevention. Today's guest, Carolyn Thomas, is the creator of a popular blog called myheartsisters.org, which addresses many heart health issues affecting women, and to date has over 17.4 million visits. She is also the author of the popular book, A Woman's Guide to Living with Heart Disease. So, Carolyn, thank you so much for taking the time out of your busy schedule to join us on Call with Dr. Dave.
Thank you for inviting me, Dr. Dave.
So, what's fascinating about you is that you're not just somebody who's interested in heart disease and helping people prevent heart disease and heart attacks. You're somebody who actually was affected by heart disease, and it happened May 2008. So why don't you fill us in on how this all started?
Sure. May 2008, perfectly normal day. I was out for I'm an early morning walker at about 6:30 a.m. So I was out for my walk, and suddenly, out of the blue, I experienced these horrific symptoms that just about floored me. Central chest pain, a wave of nausea, sweating way out of proportion to my walking exertion, and pain down my left arm. And it was so bad that I had to stop, and there was a big tree right in front of me, beside me. So I leaned against the tree. And I remember my first thought was, this better not be a heart attack, because I do not have time for this today. Like, maybe tomorrow, but not today. And it took about 15 minutes to calm down and notice that the symptoms seemed to be easing up. So I very cautiously took a few steps to see if I could manage. And yes, I could seem to be able to walk. And so then, like a lot of women, I thought, whew, that was weird, but glad that's over. But I had to walk past our hospital that has a heart institute attached to the hospital. I had to walk right past the hospital where I worked, by the way. I worked in the hospital in the palliative hospice and palliative care ward. So I'm walking past the hospital, and I thought, maybe I should just pop into Emerge and just get this checked out. And it was the pain down my left arm that really frightened me. You'd think the chest pain would frighten me, but I think I remember hearing or reading something about arm pain being a possible sign of heart attacks in women. So I went into Emerge, which I always tell my presentation audiences of women that this was the only smart thing I did during the entire heart attack episode. I went straight into Emerge, and they rush you right to the head of the line if you say, I think I'm having a heart attack. And I had all of the appropriate diagnostic tests, which all came back normal, which is not that unusual for women, I learned much later. But what the doctor did say is that he said, you are in the right demographic for acid reflux. Go home, call your family doctor, you'll get a prescription for an antacid drug. Well, when I left, I felt so embarrassed because I just made a big fuss over nothing but indigestion. So when my symptoms returned, which of course they did, I was thinking, well, at least I know it isn't my heart, because a man with the letters MD after his name told me quite clearly, this is not your heart. So I was popping Tums and Gaviscon and all of these meds while I was waiting for my family doctor to get back from her annual holiday. And I wasn't really alarmed because I knew this was not cardiac at all. And it was that embarrassment about making a fuss over nothing that kept me from doing what I should have done, which was to go back immediately, as many times as I needed to. And now I tell women in my audiences, you know your body. You know when something is just not right. But I was not paying attention to those messages, even as the symptoms became worse and worse. And one of the reasons, well, there were many reasons that I didn't go back. I sound like a crazy person now in hindsight, but one of the reasons was that my stereotype of what a heart attack looks like didn't match how I was feeling. Because if I ever thought about heart attacks, which was approximately never, but if I ever did, I pictured a man, always a man, an old man, old fat man out on the golf course, and then suddenly clutches his chest, falls down unconscious. That to me was a heart attack, and I didn't have that. I could walk and talk and think, drive my car. I went to work every day. I flew halfway across the country for my mom's 80th birthday, having these horrific episodes nonstop. And when I finally got back, it was coming back on the plane from my mom's birthday, a 5-hour flight, that I decided I was going to go back to Emerge. But again, I still wasn't thinking heart. I was going to get serious antacid drugs, possibly IV, because I knew I could not, I had to go back to work the next day, and I thought, I can't work like this. Like by now I was so ill, I couldn't walk 5 steps in the airport without stopping. And so when I got back the second time, again, not for my heart, I wanted to get some serious drugs. And this time I could tell, though, by the looks, I must have looked like death warmed over. Oh, I'll tell you this funny story. My nurse friends think this is the funniest part of my heart attack story. My flight was a very late flight. It landed about 2:00 in the morning, but there's no way I was going back to emergency at 2:00 in the morning, because as all nurses will tell you, Emerge is a zoo at 2:00. And so I decided I would wait until after shift change, about 7 the next morning. So I just went back, I crashed into my bed with my coat and my boots on, and I just basically waited for shift change to finish. And then I went back to Emerge, and that's when everything was very different. Everybody swung into action. This time, all of my diagnostic tests came back. As the cardiologist on call told me, he said, I can tell by your T waves and all of your diagnostic tests that you have significant heart disease. And my question was, in my stupor, I said, but how could that be? Because this very hospital just 2 weeks ago sent me home. And he said, well, your diagnostic tests at that time came back normal, and that is not that uncommon in women. And they also sent me back very fast. I was home within 4 hours. And as you know, when you do your troponin, usually they're the cardiac enzyme tests, they're back to back, but a couple hours apart. Well, I had my bang, bang. And as he said to me, your first blood test came back normal. We're going to do a second test, but it will be normal too. So I think from a diagnostic point of view, he'd already moved on. His differential diagnosis was no longer cardiac. As soon as your diagnostic tests come back normal, you can pretty well kiss a cardiac diagnosis goodbye. Really, that's the truth. Unless they admit you for observation, which is quite common if you're a man. And as one of the women in my audiences told me once, she had overheard a conversation. She was in emergency for a non-cardiac reason, but she overheard a conversation between the male patient in the curtain next to her bed in Emerge and the doctor in emergency. And the doc said, all of your cardiac tests came back normal, but we're going to admit you for observation just to make sure it isn't your heart. And that's what the guideline protocols suggest, that you don't send somebody home who's having central chest pain, nausea, sweating, and pain down their left arm. So I now say, I wish that that doctor had just Googled my symptoms because I'm pretty sure that Dr. Google would have come up with myocardial infarction at the time, but he didn't. And I fit the profile. You know, I was a middle-aged woman who looked like, he said, have you ever had acid reflux or GERD? And I said, no, never. And he said, oh, well, now you probably do. So I think that dismissal makes it really hard for women, for anybody, to go back to the same person who has already told you there's nothing wrong with you except this minor little indigestion problem that you can fix with an antacid pill. So that's in a nutshell, you know, how I happened to survive that episode.
I mean, it blows me away, your whole experience, but unfortunately, I don't think it's that unique. I have a feeling this scenario happens in the United States and worldwide, Canada, every day.
Yes.
Every single day,
Every-
women go to the emergency room with symptoms, maybe not the Hollywood heart attack symptoms, although in your case it was pretty close, with vague symptoms, and they're told it's something else. I'll tell you what bothers me about your entire story. The most important thing was that the doctor said you did not fit the demographic. And to me, that's very telling about the medical establishment and our education, that most of heart disease and the studies on heart disease are in middle to older white men, right?
Yep.
So
Yep.
for us to say you don't fit the demographic is really ridiculous, because we don't have a lot of studies for that demographic. We have studies, but not a lot.
Yep.
So it makes me very, go ahead.
Things are getting better now. I'm happy to say this was 12 years ago in my case, and there are studies, emerging studies on women, because women were either not included for 4 decades, basically. Most cardiac studies have not included women, or they've included women in statistically insignificant numbers, or the results were not parsed according to male and female sex. So we don't know what the assumption, I guess, was that if it works for men, it should work for women. And
Right,
in
exactly.
most cases, that's not true.
No, absolutely not. So, okay, so in your case, you were lucky. You were just lucky. You were lucky you did not die from heart disease, because
I was so lucky.
You were having unstable angina. You were close to a heart attack walking in the airport where you couldn't even walk 5 feet without stopping.
I know, crazy. It's crazy. I was close to death on the plane. I had 2 severe episodes on the plane. And at no time did I think I should really call the flight attendant over, because I knew I'm in serious trouble here, because I did not want to be one of those passengers that they have to turn the plane around for a medical emergency. Like, how embarrassing would that be for a case of indigestion? So I just sort of hunkered down. And the funniest part, having a heart attack is not funny, but in my case, there's so many things I look back on that think that is hilarious. It was the first time in my life I'd ever flown business class, and all around me in business class, these people are having their champagne and their chocolates, and I was just curled up and refusing everything. Like, no, just leave me alone. I'll be fine. So it was really annoying.
That's what you were doing. No chocolates for you. Just surviving a heart attack.
I'm busy.
I love it. So, all right. And I think what you're teaching all of us, myself included, is that there is clearly, or has been, and I think you're right, I think things are getting better. I don't think they're where they need to be, but they're getting better. But clearly there is a dichotomy in heart disease care between men and women. And
yes,
hopefully that gap every year is being narrowed. And because of people like you and a lot of influential cardiologists, in particular women cardiologists, I think we're definitely seeing significant improvements. But on your blog, you have, my favorite section is the myths and facts section. Because even as a cardiologist who's been doing this for about 18 years, I'm still amazed at these facts. And it's as if, and I've read them before, but it's as if I've read them for the first time. So let's go over a couple of these myths and facts. And I just want your take on these. First one's going to be a fact. The next 2 will be a myth. The first fact you have, and this is what really blew me away, and I'm just going to take it right from your blog. Very few doctors appreciate heart disease mortality in women. An American Heart Association study showed that only 8% of family physicians and 17% of cardiologists knew that heart disease kills more women than men. That's scary. So
Yeah. Now that is an older stat, and I'm really, really hoping that that stat's improved. But you may have heard of the survey that was just released a couple of weeks ago from the American Heart Association. It was the 2019 National Survey on Women's Heart Disease, specifically how aware women were. Doctors are another category, but how aware women were, given that we've had decades of the Go Red for Women campaign, the Red Dress campaign. February is Heart Month. So we seem to be on this path where we're raising awareness in women and in clinicians. And the results were so shocking to me. I had to have a wee lie down after I read the survey, because I just thought, number one, why am I doing what I'm doing? Why, I'm just a volunteer noodling away on my blog and speaking in public to women about heart disease. But why am I doing this? Because the stats were not only low, they were worse, significantly lower than they were 10 years ago, the last time the AHA did this survey. Now that's incomprehensible to me. For example, only 52% of the women surveyed knew that chest pain is a symptom of a heart attack. I couldn't even believe that. How is that possible? And what do we need to be doing better to get that message across? Because clearly what we're doing is not working. So I still don't know. I read this really interesting article published by an American journal. Two Florida researchers at the University of Florida did a piece called "Stop Raising Awareness Already." That was the title of their paper. And they gave all kinds of reasons about how when we try and raise awareness, whether it's with physicians or with women themselves, we think that giving more information will change behavior. And what the behavior scientists tell us, that hardly ever works. If it worked, then every parent would be getting their kids vaccinated. Mm-hmm. Because when we see that, vaccination rates are dropping, this is off topic, but it's a perfect example. When we see that vaccination rates for things like measles and polio and, really scary childhood diseases, when we see that that's dropping, we think the way to correct that is to give more and more information, more information, more information. And clearly, this is not getting through to the people who are making those decisions. You can give all the information you want. If you gave that information to a bunch of pediatricians, I bet they would absorb it, because that makes sense with what they believe, what they've learned, what they've studied, and their colleagues all believe the same thing. But we're talking to such a mixed group of particularly women, that we can't treat everybody the same way, as if they're all, white, college-educated, privileged women. And that's how we've been treating them. We'll just give you lots of information on shiny, glossy brochures, and we'll do these fancy little websites, and we'll invite you all to a red dress fashion show once a year in February. Well, those are all fun, and they all make us think that we're doing something for the cause. But what the Florida researchers are saying is, no, sometimes it can backfire, actually, and people just shut down. So that phenomenon is very interesting to me, because honestly, I don't know how I personally, even when I wrote an article about the results of the survey last month, my urge was to start giving stats and facts and, did you know, don't you know this? But I was just regressing to exactly what they tell us doesn't work. So I don't know. I honestly don't know.
I thought, and I agree with you 100%. It's a little counterintuitive. You would think, because if you look at marketing in general, the more you're in people's face, it tends to work, at least when you're selling a product, maybe not healthcare or a disease condition. But, to me, I really think it has to come from the clinicians. Because two things. Number one is clinicians are trusted.
Yes.
And clinicians have that opportunity when I'm in the room with a patient. It's very personal. And we have that opportunity. We have the undivided attention for the most part. There's no slant. We have the opportunity to educate them and to tell them. My thing is this, and it comes a little bit from your website, actually. We deal with a lot of type B personalities, right? And I learned that from your website. I never even heard of type B. They're all in my life. I have lots of type Bs in my life. I didn't know what it was, but now I know what it is. It's type B. But what I tell people, especially women, is don't do this. And I tell men this also, because men, the slant is they're the breadwinners for the most part. I'm being sexist. I apologize. But for the most part, they tend to be the breadwinners. They have been. So my line is, you're not doing this for you. You're doing this for your family, because they need you to be around. You need to be vertical. All right. You're the provider for the most part. You need to be there. And I'll say the same thing for women too, who are the breadwinners. But what I tell women, and it does work, is I tell them, you're not doing this for you, because women couldn't care less if it was for them. They couldn't care less. But once you tell them it's for their kids, it's for their husband, it's for their aging parents, that if something happens to them, everybody else is in trouble. Then they listen. So you take
that's so important. And that business of you are a trusted person in that person's life. So you have a unique opportunity as a clinician to send a message that's really, sort of laser-like focuses on what's important to that person, as opposed to some blanket message that's up on a billboard that I drive by every day, but may not absorb it. But what you said is so true about listening to the doctor. And an example of this is cardiac rehabilitation. We know that women are far more likely to be dropouts of cardiac rehabilitation, which is usually a supervised 2-month program, a couple times a week for new heart patients. And we know from many, many studies that going to cardiac rehabilitation, completing your session of supervised cardiac rehabilitation, will significantly lower your risk of having another heart attack. So this is something that all doctors everywhere should be recommending. And we also know that there was a horrible study. I think studies are horrible, by the way, if I don't agree with them. So horrible study a few years ago that said the referral rate of cardiologists is as low as 20% of eligible heart patients. I had to have another lie down after I read that, because that would be so easy. And now we have a computer screen where they tick a box, because when I say this to the medical audiences at conferences, inevitably some cardiologists will put their hand up and say, oh no, I do it for every patient. I click the tick box on my screen. That is so not the same. It's not the same as taking 11 seconds with the patient to say, listen, there's this program, it's called cardiac rehabilitation. It's fantastic. I love it. I would love it if you would sign up, because then you're raising your chances. You won't have to go through this again. And that's all it takes. And we know that physician endorsement is the #1 predictor of attendance and completion of cardiac rehab. So since we know that, why aren't all doctors getting on board, as opposed to saying, well, I clicked the checkbox, so in her discharge papers, there's probably something in there, or some stranger's going to phone this person a week later and say, you don't know me, but I'm here to sign you up for cardiac rehab. And people are already overwhelmed and stunned, and I don't know this person. And now you tell me that it's not going to be covered under my insurance, or that my copay is going to be $400 and I don't have $400. So those are the kind of issues that I'd like to see not corrected, because in medicine it takes years and years and years, even for research. I read 17 years recently to go from research from the bench down to the bedside with the doctor. It can take years for that to trickle down. So you and your colleagues have a great opportunity, because you're right there. You're right there with the patients. And I wish all doctors knew how important that connection was, in terms of not getting the patient to change, because nobody wants to hear, the way you are, change. Nobody wants to hear that. But if they hear from their doctor, who has a personal interest in them, and they trust that doctor, I think it goes a lot farther than just ticking a checkbox on a computer screen.
Yeah, that's very well said. I have nothing to add to that comment. I agree wholeheartedly, and I think it has to start, between the doctor and the patient, and for all the reasons you mentioned. Um, and there's just so much misinformation out there. And again, I think it has to start with the health professional. But I want to ask you this, because this is a thorn in my side, and it bothers me a lot. And I think about this every single day. Every single day, I think about this. I feel heart disease in general, and we will, especially in women, is totally neglected in terms of screening. Now, that's for many reasons. Number one is, and this you can get 10 cardiologists in the room, and we will debate like rabid dogs about how to screen patients, right? We will
Yeah.
debate until we're red in the face how to screen a patient. But we use these risk scores, Framingham Heart Study, right, and multiple other risk scores. Most have not been studied in long randomized trials, but we still use them because it's kind of the best we have. But we do have some technology, emerging technology. It's not really an emerging, it's been here for a long time. And I wanted to pick your brain on this because I know you go to a lot of conferences, but one of the tests I use a lot, and the more I use it, the more I believe in it, is the coronary calcium score. It's very controversial. Shouldn't be, but it is. It's a test that every president of the United States gets before they take office. And I know all the scores from the last 4 presidents, by the way. It's a test that every astronaut has to get before they're enrolled in NASA. And it's a test that I think every citizen in the state of Texas, because of the senator who wound up getting the test and subsequently having bypassed because of it, had. So what is your experience? What are people talking about? I mean, Canada is a little bit different than the US in terms of healthcare delivery. But any thoughts on how should we screen these people other than just saying risk factors? Because we know a lot of patients who have risk factors or don't have risk factors. Some will have disease and some will not. So how can we refine that?
Well, I'll answer your calcium scan question first, which is the same way I answer every question when my blog readers send me questions and say, here's my situation. What do you think? What should I do? I always say, I am not a physician. I have never been to medical school. I have no medical training. So I'm not qualified except to say that I know it's controversial. And this is, again, getting back to educating your patients. Why is it controversial? If doctors, here's how an average patient would look at this, is that if doctors can't agree one way or the other, and I follow like every conference. In the olden days, I used to attend the conferences, not as a participant, but as I get media accreditation so that I could go with a press pass, because I wanted to interview the researchers who were working on women and heart disease. So just as an aside, the very first time I went to a medical conference with a press pass as an accredited media reporter because of my blog, there were 700 papers being delivered. It was a cardiology conference, 700 papers over the course of 4 days. 4 of them had anything even remotely to do with women's heart disease. So that's the state of the profession. So things are better. The next time I went, there were 12, but still, you can see that the interest, you can see where the interest level is, and it's generally not with specifically women and heart disease. Anyway, I got so sidetracked, I forgot where we were going. Oh yeah, calcium scans. So I'd like to see, I've been to these conferences, I have heard these debates in the, somebody's presenting a new paper or a poster presentation, and they're just pummeled with questions and lots and lots of controversial things coming out. And then whenever that happens, I do a little cringe, because I think, what is the poor patient supposed to believe? Should I believe this guy who sounds very articulate and went to medical school and seems pretty smart? Or should I believe this guy who went to medical school and seems pretty smart too and is very articulate? Maybe I should believe him. So a lot of patients are saying, I don't know. I will tell you that there's a stereotype here in Canada, because our system is very different than yours. But I remember seeing pictures of these huge, big 18-wheeler trucks, like they're a block long, and they pull into the Walmart parking lot, and on the side of the huge big truck. There's a sign that says $99 heart scan.
Yeah.
And people are lined up at the Walmart parking lot. Well, that is not the way to convince people that this is a good thing. But many clinicians like you use these scans and trust them, and they give them information that is really useful. So I think that the doctors have to figure this out first before the patients wade in with, you know, what I never, when someone says, should I get a heart scan or a full body scan? I just say, talk to your doctor, talk to somebody that you trust and have that conversation.
Yeah, I agree. And I don't think it's for everybody. I mean, I can't stand the ideas of those trucks, because for a million, I could give you a million reasons, but the most obvious one is there's no follow-up. You know, they get a test and then nobody acts on the test, and,
Yeah.
you know, it's almost a waste of time. So, you know, going back to women and heart disease, one thing on your website that really blew my mind, and I actually read it a few times, is you mentioned an Oregon study that found up to 95% of women experience early warning signals weeks or even months leading to their cardiac events. 95%. That's startling.
I know. Isn't that shocking? And that's that little voice that something is wrong, that they don't pay attention to. So when that many, this is what you would call prodromal symptoms, right? Like they're early warning symptoms. They're not enough for you to go to the doctor or call the doctor or go to Emerge, but there's just something, so that after the fact, all this research was done on women who had been diagnosed post-op or post-stent or post-diagnostic appointment. And so they were all heart patients, and they were asked about, was there anything along the way? Did you have any hint that something was up? And 95% of them said yes. And then the list is quite narrow. Like, and it wasn't like, yes, I had crushing chest pain. And it like fatigue, crushing fatigue in a really unusual way. Fatigue, like not your normal tiredness, but because what woman does not feel tired, right? So we're not going to run to the emergency department just because we feel tired. But there's a small number of really common early warning symptoms that were shared by 95% of the women. So I say to women in my audiences, I don't want you, next time you're tired, I don't want you to all run, you know, to emergency because you're tired. But what I tell my audiences, this business of, you know, your body, you know when something is not right. And what would you do if it were your daughter having this same symptom, or your mom, or your sister, or your best friend? Would you say, oh, just hang on, honey, it'll probably blow over tomorrow? No, you would probably be counseling that person you care about. You need to seek help. You need to ask for help. And women are horrible at this. As you said, Mayo Clinic did a really interesting study on women's priorities, because they too wondered, for example, women wait longer to seek help in the middle of a heart attack compared to men. And Mayo Clinic did this study on women's priorities. They asked women, what is most important in your whole life? Like, what would you say is most important? More important than having a heart attack. Like when I was leaning against the tree, I'm thinking, today is not a good day. This is not a good day for me to have a heart attack. So the number one answer that women gave in this Mayo study was family, children specifically. If you have children, you will drop everything for your kids. And this is true whether they're little or whether they're big, like my grown-up children. Number two was home. Our homes are very important to us, how they look, how clean they are. Nobody ever walks into your house and says, boy, is he a messy housekeeper, right? So women feel very responsible for their homes. Number three was work. I hope I get this order correct. Workplace, relationships, income, self-esteem, all of these things that make it work very important to women. I always ask my audiences to guess what the next one is. And this is usually where women say, husband. And I say, no, husbands are on the list, but not yet. So the next one is pets. We love our pets, don't we? And after pets is the spouse, right under the dog.
Right under the dog. I
Right
like
under
it.
the dog, yeah.
Right under the
And
dog.
what's the last priority on that list is ourselves,
Amazing.
ourselves. Oh, isn't that pathetic? So that means after the kids, the home, work, pets, husband, then we will meet our own needs. And every day I hear from women who tell me their treatment seeking delay behavior stories. And there is an entire group of research. I didn't even know this existed until after, because I was like the poster child for treatment seeking delay behavior. And afterwards, I started researching and found some fantastic studies, like out of Oregon, not a different researcher out of Oregon, but that said, this is so common in women, and we know that it's affecting their outcomes. So as you know, the longer you delay treatment for a heart attack, the harder it is to have a good outcome because of the heart muscle damage that's happening in the meantime. So doctors are very concerned about why women delay seeking treatment. And I think that's that's a systemic thing. Like there's nothing that I can say in front of a group of a few hundred women that's going to make them all rush to emergency every time they have a symptom that they don't like or they haven't experienced before. But it's a systemic issue. It's the way we were raised. It's putting everybody else first. And there's lots of emerging studies that suggest this is true. So there was a study out of the UK on men and their treatment seeking delay behavior, which is virtually, well, I won't say it's non-existent, because there are some men in these studies who were too tough to seek help, right? It's not, I can stand it, it's not that bad. And in the UK study, though, that concluded that men fare much better than women after a heart attack. And I looked at the study and I said, well, duh. Men have wives. That's why. And if a man says, oh man, I feel horrible, my chest hurts, the woman says, that's it, we're calling 911. And even if the husband says, no, it's okay, she said, no, we're going. So whereas women will argue with their husbands, this is what the studies are telling us, and this is what the women say too, that they'll say, oh honey, I feel horrible, I feel awful, this is bothering me and that's bothering me, and husbands say, honey, you look bad, we should call 911. And she'll say, no, if it's still bothering me tomorrow, maybe I'll call the doc tomorrow. So we will fight against that because something more important might come up. Right. So one woman, for example, who was in one of my audiences, her heart attack signs hit on Christmas Eve, the morning of Christmas Eve. And hers were like mine, Hollywood heart attack signs, like massive chest pain. And her grown son was with her, and the son said, Mom, we've got to call 911. You look horrible. And she said, honey, I've got 12 people coming for Christmas dinner tomorrow. I can't go to the hospital. So in our sort of crazed way of looking at life, that seems like a reasonable thing to say. But if we heard somebody else say that, like our mom or our daughter or our sister, we would correct them immediately. So we will take action for somebody we care about, but not for ourselves. So that's the issue that I urge women to take a look at.
You know, it's so interesting because as I'm listening to you, if I was to create a campaign for women and heart disease, which you said correctly before, many times it doesn't work. If you just throw on a billboard, you should be screened. But if I was a marketer for the American Heart Association, I think I would strongly consider the type B personality when reaching out to women and making sure they understand, okay, we get it. You don't want to burden people and you're putting all these other things ahead of you. So let's talk about those other things, you know, your family, your husband, your pets. These people need you. You're the foundation. And I think that would be very interesting to look at if you phrase it that way and then saw how patients or women behave based on that.
Mm-hmm. Yeah, obviously you've got to reach women where they're able to listen to you, and what they're listening to is this going to help my child? Is this going to help my family? It's going to help my spouse, my workmates. So it's hard though, because we've been socialized for thousands of years. This is not a new thing, and it's not just cardiology. It's the same throughout all specialties in medicine. I'm sure would tell you exactly the same story. I just happen to be writing about women and heart disease. but I don't know if you've read Maya Dusenberry's book called Doing Harm. It is the history of medicine as it applies to women patients. And it is so shocking that I warn people now. I was asked to do a review of the book, and I said in my review, warning, do not open this book before you take your blood pressure medication, because it is the history of women not being, women being dismissed, or women being misdiagnosed, or women's issues not being taken seriously. That's the history of women. It's not just women in cardiology. It's Maya Dusenberry looks at women across all different aspects of medicine. So it's a pretty big issue. Like, it's bigger than you can solve with your patients, and it's bigger than I can solve with my blog or my book. But I like to believe that we're making some difference, that we're making some progress, and that and I've heard this personally, just strictly anecdotally, not a study, of course, but I've heard from many, many of the women that I've spoken to, or who have read my blog or read my book, said, I remembered what you said, and so I called 911. You know, that to me is like, okay, now something is happening.
Yeah, there's an old Jewish saying that if you save one life, you save the world. And, I really think that what you're doing is definitely making a huge difference. And even if it's only one person, it's worth it. It's worth every second. And that's what we do here. I do here is we're trying to get awareness out. I wanted to ask you another question that bugs me a lot, because, I'm busy. I see a lot of patients. If I ask, we'll talk about women. If I ask a woman patient, did she have her heart checked, or did she have maybe her cholesterol checked? They look at me a little weird, like, why is he bringing this up? Yes, he's a cardiologist, but does he know something I don't know? But if I ask that same patient a moment later, did she ever have a mammogram? Let's say she's a middle-aged woman. I mean, it's like a reflex, of course. Like, now they're looking at me like I'm crazy for asking, how dare he ask me if I had a mammogram? Of course I had a mammogram. But they didn't think to have their heart screened in some way, or they didn't think to have their risk factors addressed. It's always oh, my cholesterol is high, my doctor told me to exercise and diet, and he'll check it again in a year, or she will. But, you ask about mammogram, oh my God, that's the third rail. You can't even touch that. Of course I had it. Why is that?
Yeah.
What is it about breast cancer? Mammograms are incredibly important, no doubt about it. But how can we learn from our colleagues in oncology who've been so successful in teaching women that they should have a mammogram? How do we do that in cardiology? How can we get women to say, of course I had my heart checked, or I was screened for heart disease?
That's the question, isn't it? I've written about this. I tend to write about it every October, which is Breast Cancer Awareness Month. And my entire work background before my heart attack was in public relations, in corporate, government, and nonprofit sectors. And so I know a lot of my colleagues in public relations who work for the cancer agency. And I have to say, they have done a fabulous, just a bang up job in convincing women of something that is not true, which is that breast cancer is our biggest killer. Most women in my audiences, I often say, what would you say if I asked you, what are you most afraid of? Like, what disease or what condition are you most afraid of? What do you think is women's biggest health threat? Invariably, women will say, breast cancer. That's what they think about, that they're most afraid of. They're not afraid of heart disease because that doesn't affect them. It affects men, right? So, and I was the same way. I never thought about heart disease any more than I would think about lupus or anything else that does not affect me. But breast cancer has done a fantastic job, not only in raising awareness. I mean, and let's face it, is there anybody out there who needs to be aware of breast cancer? Breast cancer has had a really interesting history, though. There was a time when the word breast cancer couldn't even be mentioned in the newspaper in an obituary. So they have gone from nobody knows about us to everybody must know what is happening here. And then that grew into encouragement for screening to see if you can get it early. And screening is very controversial. it's kind of like your calcium scans,
Yes.
right? There are doctors who think it's the best thing, and then there are other scientists or researchers who are saying, we don't have the data to say we know that early screening means early or prevention of breast cancer deaths. There doesn't seem to be that connection, and yet you've got women who are totally on board for mammograms. Yeah.
Totally.
So if I knew, I would be doing it, but
Yeah,
I don't.
I mean,
Yeah.
same thing. I would even argue for colonoscopies. And even recently, I think there's a push, or that maybe they have decreased the screen age to 45. And I'm a huge proponent of screening early when it's appropriate. But I'm always amazed that when I ask somebody if they had a colonoscopy, or a female, if she's had, middle-aged female has had a mammogram, they look at me like I'm crazy. Like, of course I'm going to get a colonoscopy every 10 years. So I don't know. It's something we struggle with. And maybe it is, we need that tool. Maybe we need the coronary calcium score, or carotid ultrasound, or something else that can screen early. Because as you know, the stress tests that we do are really looking for advanced disease, but we've lost that we're waiting for advanced disease. We need to get the disease early because we can modify it. Right?
Yeah, I agree. And there's still some people, right after my heart attack, I applied for a fantastic training program at the Mayo Clinic in Rochester, Minnesota. And it was called the Science and Leadership Symposium on Women with Heart Disease. And so there were 45 of us in my little group from all over America. I was the only Canadian. I felt like I was in the Olympics representing my country. And we had 5 days of world-class lectures from all women cardiologists talking about every aspect. It was like cardiology boot camp. It was fantastic. And what I learned there was so shocking to me. Shocking about how under-aware women are in general. Certainly I was. But when I looked around the group, for example, we had triathletes in my group of 45. We had vegans. We had a physician who was the most surprised person in that room. She didn't see it coming. She didn't see herself. Like, nobody in that room saw themselves as the kind of women who have heart disease. And that's because we don't think about heart disease a lot, if at all. We have no interest in something that we believe does not affect our lives until somebody we know or we ourselves become diagnosed. Then suddenly everybody in the family is concerned. So I was a distance runner for 19 years before my heart attack. So some people would say, do you remember Jim Fixx? He sort of invented marathon running as a recreational sport, and he died during a run. And all of the couch potatoes in the world sat back and said, well, that's where running will get you, right? Here's this super duper marathoner, and he drops dead during a run. But Jim Fixx had outlived every male relative by at least 10 years, probably due to that running. Right? Because he had a horrible, his cardiac profile was just awful, but he ran. So maybe my 19 years of running postponed my heart attack for 10 years. That's how I choose to believe it. And my cardiologist talked about collateral arteries after my heart attack, because we know that when the heart is stressed, those little collateral arteries magically grow around blockages. So maybe that's what kept me alive during that 2 weeks, which sounds insane that I would have been able to survive that. So, but it's hard to convince a woman that if you run for 19 years, you may survive a heart attack. It's so out there and not relative to me. So we know that if you have, for example, I know I keep getting waylaid, but there's so many great examples out there. So I was asked by an American publisher to review a new book by a woman who'd written a book about, sort of a memoir, about her own cardiac event. And it was really interesting, the first, the symptoms and the first little lead up to getting admitted to hospital. And then she mentions, sort of casually, that she'd been a chain smoker for 30 years and smoked 3 packs a day. But she was so shocked that she had this heart attack. And I thought, how could you be shocked? Like, you never, clearly the link was not there. In spite of, talk about information. Is there any category of risk factors that have more play than smoking? Smoking is bad for you for these reasons. So that's that's kind of where we're at.
Yeah, I mean, I think you summed it up beautifully. We've made progress. There's no question about it, but we have so far to go. And, I think the most important thing is just getting the word out for people to speak with their clinicians, speak with their
Yes.
healthcare
Yes.
provider. You know what?
Yeah.
Also, and I'm going to say another thing about going back to your story. Your story teaches us that you have to be your own advocate.
Yes.
You,
Hmm.
you cannot let the healthcare professional, healthcare industry, if you want to call it that, dictate everything about your care. I have a very simple rule with my patients. If somebody keeps complaining, we keep looking. It's a very simple
Yeah.
rule. It seems to work. But the thing with
Yes.
you, which was very interesting, is maybe you didn't really advocate well for yourself initially. But
Not
if
at
not at
all.
all, but if you have, I know it would be very different if you can go and do it again. But if you have symptoms and you see your doctor and you're not satisfied because you're not getting better, either go
Mhm.
back to your doctor or get a second opinion. But
Yes.
keep going.
Mhm.
Be the advocate. Don't stop.
Yes.
Your body is telling you something. It may not be dangerous, but your body is telling you something is not right.
Yes, so true. I'm so glad you mentioned that because that's the key, isn't it? But there's a real hierarchy in medicine that still exists, especially when you're the woman patient. And if the doctor, if it's a male doctor who says, there's nothing wrong with you, here's what I think it is, blah, 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 get out of my hair, then most of us will say, okay, he's the doctor. And it's very hard to say, but doctor, here's what I met a woman at my Mayo training who did this. She was sent home 3 times from emergency because of her symptoms, but she kept going. She was way smarter than me. She kept going back. And the 3rd time, she was given a prescription for anti-anxiety medications. The 4th time was for double bypass surgery. But I like to tell this story to my audiences because I say there's a smart woman who kept going back. She basically was saying, I don't care what you say, something is wrong with me. I know my body. Something is just not right. And I wish I had been that brave. But I had another experience, which I hadn't mentioned yet, just quickly. As I was after, I think it was between my first and second normal troponin test in emergency, the emergency nurse came to my bedside and said to me very sternly, you will have to stop asking questions of the doctor. He is a very good doctor and he does not like to be questioned. Well, I was so shocked to be spoken to like this by a nurse. And remember, I worked in this hospital. I'd have lunch in the hospital cafeteria with this same nurse. So when she sort of scolds me like I'm a naughty child, I could not get out of there fast enough. Not only have I embarrassed myself by making a fuss while all the truly sick people were waiting in the waiting room and I was wasting their time, but now I'm the difficult patient. She's telling me quite clearly, don't ask questions of the doctor. But the question that I was asking, I thought was a pretty reasonable one, which was, but doctor, what about this pain down my left arm?
Yeah.
I think that's a perfectly reasonable question. But even to be questioned was apparently not acceptable in that particular waiting room. So it's hard for a woman to keep going back like that Mayo woman that I was telling you about. It's really tough. So I really urge women to do that. If what would you do if it were your daughter?
Yeah.
There's a great scene in that old Shirley MacLaine movie called Terms of Endearment, which is a movie about a mother whose daughter's dying. It's a real tear fest if you ever feel like, emoting, where she comes running out into the hallway of the hospital and because her daughter is late for her pain medication injection, and she is screaming blue murder. And all the nurses are saying, yes, we'll be right there. As soon as I finish this report. And she says, no, it's after 10 o'clock. It's after 10 o'clock. My daughter needs her shot. And she screams and hollers and is a very difficult patient until the nurses stand up and run into the daughter's bedroom. That is what we all should be doing for ourselves. Not that we have to scream because we know we don't want to be a difficult patient, but we have to be, like you said, we have to be our own best advocates.
Yeah, absolutely. There's so much more we can speak about, and we will definitely need to do this again because we haven't even spoken about other issues with women in heart disease, but we will.
Good.
So I know you're busy. I just want you, can you just share your blog, and also where can we get the book? Because I think the book is really important. It's empowering for women, and honestly, it's empowering for everybody to read. So where can we locate that book?
The book is called A Woman's Guide to Living with Heart Disease. It's published by Johns Hopkins University Press, and it's available in any bookstore. They'll order it for you. You can get it on Amazon if you just Google A Woman's Guide to Living with Heart Disease. And the blog is myheartsisters.org.
Great, and I'm going to put that link below. So, Carolyn, I've learned a lot during this conversation, and that's why I love being a cardiologist, because I learn every time I speak to people like you. And I know we've all learned, I'm hoping our viewers have learned something today. And I appreciate your time, and I look forward to speaking with you again. And, the most important thing is that we keep at this, and we don't, you can't let your guard down. You got to keep going.
Yeah. Yeah. Thank you so much, Dr. Dave.
It's my pleasure. Be well, okay?
You too. Take care. Bye-bye.
Bye.